Okay, so I'm in the minority in this meeting because one, I'm a physician and it's overrun by SLTs, and two, I'm from the Southern Hemisphere. So that changes the perspective a little bit because we don't have billing considerations when we talk about our work. So that may influence some of what you see here. This does touch on a few things that have been said in the earlier sessions. I think it'll link in quite nicely. So I guess the first question is really, well, why do we care about the esophagus? You know, we're seeing patients who mostly have oropharyngeal complaints, certainly in my ENT clinic we are. But if you look at literature, it's quite clear that a large proportion of patients presenting with cervical or oropharyngeal symptoms will have esophageal pathology. About 57% of patients who have a piece of marshmallow stuck at the LES will actually point to their sternal notch and say they feel it up there. And patients aren't good at localising where the problem's coming from. Secondly, in certain risk groups, this is going to be more prevalent, and it's not that things are exclusive. So you can have pharyngeal problems, but you can also have esophageal problems together. And in neurologic disease or certain other conditions, this will be more the case. We also live in an ever-ageing society, as we know, and the term presbyosophagus has been discussed to really talk about age-related changes that happen in the esophagus, and we're going to see more and more of this in our practice. Plus, I think probably more concerning, and maybe a little bit lower on the frequency rate, but something to keep in mind is that the fastest rising incident cancer in the Western world is actually esophageal adenocarcinoma at the gastroesophageal junction. And the number one symptom of that is not heartburn, it's not reflux, it's cough. That's the highest correlated symptom with esophageal adenocarcinoma. So we see a lot of cough patients, and if you're not looking, you're not going to find. And then the key thing for me, above all else, about esophageal screen and following this bolus is the swallow doesn't stop at the UES. It makes no sense to stop our study there and to give up on what's going on for this patient. That goes all the way down to the stomach. So we're familiar with different esophageal assessment, different tools. We can look endoscopically, we can perform manometry, pH metry, impedance studies or ultrasound, but of course today we're talking about contrast studies. And video fluoroscopy and an esophagram are not the same thing. They're certainly not in my institution. So when I think of a video study or a dynamic swallow study, whatever you want to call it, this is really a study that's focused on the on the pharynx itself and on some of the airway risk. And as we've mentioned, it's not just about aspiration, but that's certainly a lot of times what people or physicians might look at in the study. But it's up to us to make these studies worth a bit more than that. Multiple boluses and biplanar imaging is what we're going to see when these studies are performed by our speech pathologists. We see a high frame rate, as mentioned, and that's critical to the value of the study. And we have a low fluoroscopy time, as also been mentioned this morning. In contrast, when I get an esophagram in my institution, this is a view from the UES to the stomach, and it really doesn't look at the pharynx at all. Multiple consistencies are given, and it's multiplanar because often there's an oblique view that's performed by the radiologist. However, my radiologists typically will perform this study at a lower frame rate, often down as low as 3 frames a second. And you certainly couldn't assess anything in the pharynx at that frame rate, and I find it hard in the esophagus to get valuable information from there as well. They will give a bolus of either marshmallow or a tablet, and often they'll perform a Walden siphon test if there's any mention of reflux, and this does move the patient around. I'd also like to say that, as Dr. Jones mentioned, you know, gravity is often a great assistant, and we are giving people liquid swallows which are easy to follow. But I would say that not many of my patients who are eating and complain of their problems are eating lying down, so gravity might help them when they're eating too. For me, I really think that the esophageal screen is valuable because there is a group of patients who present with dysphagia or pharyngeal symptoms where if you just stopped your DSS at the UES, it would be a normal study. You wouldn't see anything wrong, and you'd send those patients away back to their referring clinician without any valuable advice or information. And for me, that's a clinical mismatch between the history and what this patient's sitting there telling you and what you're seeing. And if you don't follow things down and look for the problem, you're not going to optimise your study. And after Lisa's great talk about radiation safety, I think we can really understand how it's our responsibility to optimise the quality of the information and the quantity of information you get from your study, particularly those with ionising radiation. So we need to ask the right question, listen to the history, and direct our study or tailor it for that patient. So we have to assess the whole swallow. It's no good just stopping. We do need to challenge the patient, and we also find that clinicians who don't look after these people are maybe a little more timid about challenging patients when they do identify aspiration. I'll often find that my radiology colleagues will stop the study when there is aspiration, and that's not the end of the question at all. Liza mentioned this as well, and it is important to consider the radiation risk, the difference in the time frame between a screen versus a full esophagram. This rise in radiation-induced cancers is not hitting us yet, but it's certainly going to. Just to put it in context, we all get about 3 millisieverts a year of background radiation. If you take a flight like I have on a long-distance, long-haul jet, you get an extra 0.04 millisieverts just for your flight. So we're all absorbing radiation. And if you have just a simple chest x-ray, it's a low dose. But if you're talking about interventional procedures, the dose will exponentially increase. For us, video fluoroscopy measures around 0.4 to 1 millisieverts. We're not talking a huge dose, but if you're doing 3 or 4 of these in a year, you're already doubling their background radiation. So the idea of a screen, and this is a loose term, obviously it's interpreted differently by different people, but is to add to the video protocol. It's not something to be done in isolation. This is part of your assessment that you're doing on the patient. It is limited. This is not a comprehensive study of the esophagus, nor is it meant to replace it. So there are places to do both studies. If an esophagram is appropriate, then you would go ahead and do that. But this is a screen. This is an extra large bolus taken in the AP view, and now in our protocol we've now also added a 13 millimetre barium tablet and swallowed and followed to the stomach and screened until the bolus is cleared. Now, the expected time for bolus clearance from the esophagus in an upright position in a normal adult should be under 8 seconds. So if we're screening between 10 and 15 extra seconds and the bolus is still sitting there, something isn't working and gravity isn't helping. And this helps us to direct our further investigations or management options. And it may be that they go on to have an esophagram, but it may also be that they go and have manometry or they get an endoscopy to look at why the pill stopped in the middle of their esophagus. When initially we were looking at this, we were in a different setting in California, and we wanted to compare the sensitivity of the screening method and really, are we seeing the stuff that's useful? Does this make a difference to us? So we undertook a retrospective review where we performed a screen and a true esophagram on our patients on the same day at the same test. We blind reviewed these studies afterwards, and we graded the findings as normal. There was no change from normal, a minor abnormality that wouldn't have changed our management, or a major abnormality where we would have done something different. So these are the things that we felt were minor or major. We looked at 74 exams, 61% female, 61 years old, with a large range of indications here, solid food dysphagia being the number one cause, but also cough and aspiration. When we look at a direct comparison of the screen, and bearing in mind that this was just a single large bolus in the AP, we can see that the esophagram identified major abnormalities 75% of the time, and the esophageal screen only identified them 50% of the time. But when we look at things that were consistently seen, we can see that there's useful information to be gained. When you screen the esophagus, we could easily see stasis reflux within the esophagus. We saw bars easily, rings, and we did identify hiatal hernias. Initially, we didn't see the pill because we didn't give it, so that's why we didn't see it then. But we certainly saw pill stasis once we were administering that. It was harder to see esophagopharyngeal or gastroesophageal reflux because we didn't screen for long enough and we didn't do provocative manoeuvres. When we looked at a direct sensitivity comparison, using the gold standard being the esophagram, the sensitivity of the screen was 63%, so moderate. If we added the tablet to that, however, the screen sensitivity increased to 71%. The specificity was excellent. That is, if it was abnormal, there was definitely something going on, so that really helped. That means that the positive predictive value is good, but the negative predictive value not so useful. The interesting thing was when you looked at the agreement between minor differences, 3/4 of them, of the screens and the true esophograms also matched. We felt that to improve the screen, we consistently needed to give the barium tablet, so we are doing that now, and we're going to reevaluate the study as this happens. I think one of the questions from this is, well, who should be performing this? And this is probably an issue that arises more so here than it does at home. Speech pathologists perform the studies in New Zealand, and I think that they're the people that ask the clinical question. They maximise the value of the study because they know what they want to find out. They're also the ones that are going to perform any therapy or rehab, and they're going to follow the patient, so it guides their management. I think that a speech pathologist should be able to identify a normal versus an abnormal findings in the esophagus. That doesn't mean you need to diagnose anything, but you certainly need to say whether the transit times are long or whether there's something else that doesn't look right. And that's just a matter of seeing enough screens, and it doesn't take very long to become proficient in that. Radiologists, in my experience, tend to perform with protocol, but they don't have much information because we really write things down on forms that we request these for. So I think it makes it harder for them to optimise the study to our needs. The advantage of a screen for me is that the study time is reduced compared to an esophagram. I don't have to send them for a separate study. I get it done at the same time as my pharyngeal study. It's quick and easy, and my speech pathologists now do it as part of a routine. Overall, this is reducing the fluoroscopy time for the patient because in many cases they don't need to go on to a full esophagram. It does guide other investigations. It helps me to decide who needs further transnasal esophagoscopy or other tests. And for me, it completes the study as a whole because you've followed the bolus right the way to the stomach. So at this point, to keep to time, I'd just like to conclude that the screen, when we've studied this, compared to an esophagram, has moderate sensitivity and specificity. An abnormal screen is 100% predictive of problems, so that helps us in that regard. And the exposure to radiation is reduced compared to a full esophagram. It is improved if you use a tablet or a solid bolus, but we have to bear in mind that the sensitivity of a single bolus is limited, and that's why we do repeat boluses in the pharynx. So if there is a clinical suspicion or warranted history, then of course you order the rest of the test, which may be a formal esophagram. The screen is not meant to replace the esophagram. It's simply an extra tool that we can use to fully evaluate our patients and to give them the best optimised study that we can provide at the time. I'd also like to say that we're in the process of auditing our findings in regard to comparing if the study stopped just at the pharyngeal phase, how many patients would have been returned with no definitive diagnosis compared to those who go on to have the screen. And I think that will give us some illuminating data about the additional value of this technique. Thanks.
Ladies and gentlemen, dear Chairman, I'm very thankful that I'm invited here, and especially I would like to give my thanks to Bronwyn Jones, who brought her mission and her education to Austria by this beautiful book from Martin Donner, and that stimulated us more than 20 years ago to start with video fluoroscopy. And this is our university hospital where I'm working, and I would like to introduce a little bit the diagnostic radiologic approach for esophagus. Well, the purpose is to discuss the strengths and weaknesses of video fluoroscopy, including the evaluation of the esophagus by radiologic combined investigation with video and plain films, and to explain a practical approach for the technique and interpretation. What we have here is the classical, let's say, common view of radiologists, the static view of a carcinoma with irregular margins, and this can be seen easily with plain films. And this is from the time when double contrast was much more important than it is now, the classical problems of reflux. When we look at the diagnostic radiologic view, then of course aspiration is very important in sense of the primarily diagnostic study, but motility disorders, as mentioned already, can be seen if severe in the erect position, but without any question have to be investigated in the horizontal position. Sometimes diverticula are pretty difficult to estimate, and we need solid bolus. We need as well the horizontal position to see those diverticula who might produce problem, usually the big ones. Mild achalasia is a pretty big problem, but it produces mild achalasia with just the fluid level and transport problems, causes symptoms of globus dysphagia or maybe different, even non-cardiac chest pain. And this type of achalasia is often overlooked in radiological studies and might cause a problem. Severe achalasia is not a problem, is detected easily and can be seen even in chest X-rays. Video fluoroscopy detects simultaneous involvement of the pharyngeal and esophageal swallowing stage, so it's the ideal, primarily diagnostic test. Video fluoroscopy evaluates esophageal function by visualization of motility and bolus transport. If we do our reports, we always have to separate motility and bolus transport, that are two different things and maybe seen combined. Video fluoroscopy should be done before endoscopy to lead the endoscopist to mild stenosis. Video fluoroscopy can diagnose multiple esophageal stenosis, even those the endoscope cannot pass. Video fluoroscopy is helpful for patients with eosinophilic esophagitis, which is now a very modern, or let's say already known disease, and there are multiple stenosis, and video fluoroscopy in the horizontal position as well as tablets, very important there. Video fluoroscopy and EPDETS planimetry, endoflip, I will show you later on, is a beautiful complementary tool to estimate exactly the length and the width of stenosis. Video fluoroscopy provides a dynamic topographic overview for preoperative surgical evaluation. This is very important for reflux surgery and not new, but modern because of increasing numbers of operations. Video fluoroscopy can detect complications of bariatric surgery, as you know, a big field and still increasing. What I would like to show to you is this nice, sympathetic turtle from Hawaii, and it is moving slowly. And also my friends, my radiologic friends, are much more slowly moving than you think, maybe. The dynamic CT, this beautiful series of CT, when they scroll back and forward, these are static images. We do the CT in one slot, and what we see is just a static image, even if there are many pictures, but they don't see movements. We have this in abdominal obstruction, and in many circumstances, CT can only indirectly point in the direction of physiology. So it's very important to remain on dynamic imaging. This is an old X-ray I like very much. This is the rare phase of a swallow just seen on a plain film. But here you see a lot of anatomic detail, and these details you see on video fluoroscopy are that what we want to estimate during movement, and this is very well described in all this educational work we've seen just now. But what we radiologists also want to do, we give to our colleagues and also to, as diagnostic radiologists, a simple way of structured reporting. And so in Europe, we use, especially in the German-speaking countries, the system of the 7 functional units, where we give in our reports statements about oral cavity and tongue, soft palate, epiglottis, hyoid and larynx, pharyngeal constrictures, PE segment, and esophagus, stomach, of course, with the lower sphincter. This system of 7 units is more a kind of watching it, video fluoroscopies and X-rays, than it reflects physiologic or pathophysiologic considerations, because all of those 7 units work together, of course, but for structured reporting, which is an upcoming administrational and interdisciplinary way to talk about studies, this might be important. What I want to show you are not too many numbers, but this slide shows you a study from 1998, where you can see whether the functional units are involved or not. Most of the patients showed esophageal abnormality or no abnormality, but look at this group of around 8% of our sample where we could see combined disorders. I don't say that 8% of the patients have change of outcome because of those findings who are combined. But within these 8%, there is maybe somewhat about 3 or 4% of people who could benefit from a management if the esophagus is investigated more than in simple terms. As contrast media, nothing really has changed. We use as well the tablet, but mine is 14 millimeters because I can take grape sugar from the supermarket exactly at 14 millimeters, and it's more nice for the patients to use, so I don't take the pharmacological placebo tablets anymore. Paste is not used so often, as I heard in previous talks. Barium plus water, high volumes, I use in the prone position or in the recumbent position, just to fill up the esophagus with many swallows one after the other, to enhance some types of stenosis. Rulers are not necessary any longer, but sometimes for topographic purposes, I add the ruler to the digital measuring systems. Patient upright for diagnostic capacities, where I have to investigate up to 15 studies a day, I have to be quick, especially for the ALARA principles to reduce radiation. So if you are experienced, two lateral or oblique views include pharynx and esophagus, and this is in people without a severe problem of the pharynx, a quite useful way to go. But it cannot be pronounced often enough. We have to see patients in the horizontal position, here with a straw, but also laying on the back. I need both positions because I can see rings only visible in prone or the other way around. So it's very important to have both. And by that action, two laterals erect, two in the horizontal position as a standard procedure, followed by CO2, by bubbles afterwards, so double contrast afterwards, we come up with 0.2 or 0.3 millisievert. So we don't increase the radiation, but anyway, these studies have decreased radiation time. It's not therapeutic studies. It's just the way to go for the diagnostic procedures. 2 minutes, below 2 minutes in adults and below 1 minute in children is the principle, but this is a weakness of video fluoroscopy. It is radiation, even it's a low radiation dose, and of course, FEES has reduced the need of video fluoroscopy in our interdisciplinary groups largely, so video fluoroscopy for the radiologist is almost in over 90% a diagnostic study. The biggest problem for video fluoroscopy of the whole GI tract is the fact that few radiologists are eager to train filming, but we are happy that the numbers of radiologists now again are increasing. So let us see some typical examples. This, for example, is a dynamic study of the pharyngeal stage, but as you can see, video has a pretty good spatial resolution, but nevertheless, the most important thing is that we can see, like this Schatzky ring, we can see stenosis in 25 frames per second, and the spatial resolution is enough. It is not true that X-rays repeated with 6 per second have the same resolution, because I see rings and stenosis which are overlooked because of the whiteout of radiologists. The radiologist has a whiteout because with the blank eye I can see more than 6 images per second. So I like the video, it is less radiation, and the spatial resolution of video is by far enough. Here you see endoflip, which is a balloon and gives us a three-dimensional picture of the stenosis and the compliance of the wall. So the endoscopist takes profit of the video where to look for a subtle stenosis in eosinophilic esophagitis, and then proceeds to a detailed study, maybe with impedance planimetry. Here again you see a beautiful video, an old video of a dilation above a severe benign stenosis. And this dilation is sometimes very difficult to catch with esophageal digital series, and with the video, beautifully 25 frames or 30 frames per second is great. Another strength of video fluoro for the esophagus is to go below severe stenosis. This combination of web and upper sphincter bar, you see that the endoscope may have difficulties to pass. The same as in this case with multiple stenosis of epidermolysis bullosa. Of course, the endoscope has no chance to pass over by, but can get for other attempts of intervention a beautiful overlook. And these are the X-rays combined with the video fluoro. I love to use the tablet because I don't have a spatial problem to estimate the width. Here we have the 14 millimeters tablet, a narrowing, and we can estimate somehow, but we have to be very careful because we cannot measure the compliance of the wall, but to estimate the stenosis, the tablet is fine. So let me, in the end, give you examples of exactly those patients we see quite often and should be thought and should show us a little bit that detailed radiologic analysis of the esophagus is worth to do. This 70-year-old lady, dysphagia for solids and fluids for over 20 years, no clinical evidence of aspiration, no global symptoms. She suffers from heartburn once a month a little bit. PPI medication is taking over years. There was motility disorders detected by manometry, and no pathologic refluxes by pH monitoring. A myopathy is known and causes some weakness of the extremities, but with no substantial limitations. Video fluoro of the pharynx didn't show something special, but when we proceeded to the placebo tablet, it's stuck in the upper esophagus. What you see here is the plain double contrast. What is your diagnosis in this disease? What would you suggest? Scleroderma, that could be, sorry? Dermatomyositis? No, not dermatomyositis. It is just that what we see usually in young male adults, but here it was a lady, it was eosinophilic esophagitis, proven by endoscopic workup. And this late eosinophilic esophagitis should not wonder us, because they were not detected 20 years ago. So we see a lot of elder people with a lot of problems they might have had, numerous, countless endoscopies, and never had Schatzky-Ring, like this classical appearance of eosinophilic esophagitis. They have the small caliber esophagus, but not in that form that the endoscope could find it. So I see more and more elder adults presenting with this disease, and for those, the barium tablet or the grape sugar or pill, whatever you use in the range of 13 to 14 millimeters, is the ideal step. 30 seconds left. Yeah. So let us proceed. The quiz 2 is this 46-year-old lady lost 21 kilos after bariatric surgery with a gastric sleeve. What is your diagnosis about? This is the stomach. The lady got a meal with lunch after the first step of the investigation, and what we could prove that she almost started to vomit after a panini, and showed, well, it was a small one, and the lady was not small. So finally here you see the dilation, and this is the classical sign dynamically proven by video fluoroscopy of a gastric sleeve stenosis. So the conclusion, video fluoro provides a descriptive overview of function and morphology. In diagnostic studies, it is important to evaluate morphology and function of oropharyngeal and esophageal state. This approach avoids missing of simultaneous pathologic conditions of the pharyngeal and esophageal phase. Number, site, degree, and length of benign esophageal stenosis are best diagnosed by video fluoroscopy. So this is the ideal first test. And we know that we have combined and all that in an interdisciplinary. And these are greetings from Austria. This pure cormorant was eating that fish and died. We found him on the shore of the Danube River. And this is very easy seen by the history. The fish was just too big. I thank you for your attention and draw just your view to the ESO meeting in Paris, which also should help our patients suffering from dysphagia. Thank you very much.
Hello, I'm Joy Gaziano from the University of South Florida in Tampa, and I have kind of a unique perspective because I work in a dedicated swallowing center under the medical direction of a gastroenterologist. So very regularly, I evaluate the esophagus as part of our modified barium swallow. So today what I'd like to do is demonstrate to you via clinical example the usefulness, the clinical usefulness of evaluating all the interrelated phases of swallowing. Despite my obvious enthusiasm for evaluating the esophagus, there's actually very limited consensus on speech path involvement in evaluating the esophagus. In 2004, ASHA published some knowledge and skills papers and a guideline statement that actually endorsed the esophageal screen and spoke to the speech pathologist's knowledge of oral, pharyngeal, and esophageal physiology. Unfortunately, of course, there was no defined criterion, nor was there a protocol recommended. But the paper goes on to say that speech pathologists should have a good knowledge of the interrelated swallowing functions so that we reduce the risk that the etiology of dysphagia goes undetected. When medical specialties weigh in, there's very little support for SLP involvement as well. The American College of Radiology, in their guideline statement for performing MBS, do not include an esophageal screen, nor, of course, do they recommend speech pathology involvement in the performance of esophograms. ENT and GI also provide no written guidance, and as a matter of fact, insurers make it somewhat difficult for us to do a comprehensive swallowing evaluation. Medicare, in fact, has an edit that prohibits payment for a modified barium swallow and esophagram on the same day. And of course, there are some valid concerns by physicians of liability. So what is an esophageal screen? We've talked a little bit about that. Dr. Allen spoke to us about their paper, which was just published last year, that described their protocol of a single 20 ml bolus in AP-View, that it added only a 15-second duration and identified 63% of patients with esophageal disease. I don't know about you, but I'd rather get the answer right 63% of the time than 0% of the time because I didn't look. At the USF Center for Swallowing Disorders, we do sort of a hybrid approach because the gastroenterologist is the radiologist on record. And we scan the esophagus with both liquid, solid, and tablet, and of course have the flexibility of evaluating as in-depth as we need to try to answer the question. So let's talk about a few reasons that I believe it's clinically important that the speech pathologist goes below that sphincteric divide. First of all, we can't always determine the location of dysphagia from history alone. I'm a huge proponent of taking a good history, and I believe that most often we can determine the anatomical site and likely cause of dysphagia if we take a good history. Conversely, though, it's been shown that about a third of patients who complain of lower throat symptoms actually have an esophageal cause. We're all very familiar with the concept of referred sensation from the esophagus, and I know despite asking my patient the same question 3 times, very often I'll get 3 different answers as to what the problem is. So there's a lot of ambiguity in patient complaints. Generally, though, if the patient localizes the sensation of hang-up to the jugular notch, we might expect to find it at that level or any place below. Conversely, if they localize the sensation of hang-up below that, they're often very accurate in their sense of localization. Here's a nice example of that concept of referred sensation. On the left, the patient identifies a sensation of hang-up at the base of the neck. However, when we scan a little bit lower, we see that the hang-up actually is throughout the entire mid and lower esophagus. Another important reason to look below is that a speech pathologist and radiologist may identify a previously undetected esophageal problem. This is an example of a patient who had a squamous cell cancer of the left piriform sinus, treated with radiation therapy, and presented with new complaints of dysphagia. Certainly we see some subtle signs of post-radiation injury, including reduced hyolaryngeal elevation and some UES impairment, but when we actually look below, we identify this intrinsic compressing mass on the cervical esophagus. So that was certainly a bit of a surprise to a speech pathologist. Another example that highlights that is this patient who came in recently with a total laryngectomy and primary TEP. He had had 2 esophageal dilations at our center, and the physician wanted a repeat MBS to see the impact on the patient's swallowing function and also on their TEP use. One of the main patient complaints was prompt leakage through the TEP after initial change. So you notice very typical post-laryngectomy anatomy and physiology. We see this narrowing at the anastomosis site. We see a bit of weak tongue pump from above. With the masticated solid, again, we see quite a bit of residue in the pharynx. In a minute, we'll employ a liquid wash or a liquid push. That's a really effective treatment strategy in reducing the patient's dysphagia complaint. In this lateral view, it appears that the narrowing is fairly tight, but when we turn AP and we look below, we get some additional useful information. Notice in this view, the lateral dimension of the narrowing is actually quite patent. More importantly, though, we identify the tracheoesophageal prosthesis down here, and we notice that the placement is somewhat of a superior placement, and we notice this atonic segment in the cervical esophagus. And it's probably not the stricture that's the important culprit here, but rather this atonic segment and possibly this pocket that food is pooling in, and that's probably why the prosthesis is failing so quickly. We've heard a little bit about eosinophilic esophagitis this afternoon, and here's another example that we have been able to detect on MBS not infrequently. I think if you take a good history, very often the MBS probably wasn't necessarily the appropriate study to order. But when the patient is in your chair and you're the one that's been asked to make some decisions, it's really great to have the ability to scan the esophagus to try to help identify the problem. This was actually a 14-year-old autistic boy who was sent to us with food aversions. And in fact, he had a lot of food allergies, would only take liquids and purees. After EGD and biopsy, it was determined to be eosinophilic esophagitis, and a combined behavioral approach by the speech pathologist and a medical approach by the gastroenterologist was extremely effective. Another case was a patient who was discharged from the hospital with an NG tube and sort of lost to follow-up. A month later, he came to the swallowing center wondering if he could have his NG tube pulled. He never told people that he was on double-dose PPI for months and years, and had not been taking his PPI for some time, and had developed a pretty significant nasogastric tube stricture. So he was coming to us to see how his oropharyngeal function was, but in fact he had significant esophageal problems as well. Another important reason to scan the esophagus is we know that if one component becomes functionally impaired, another one may be affected. And this was a really dramatic case for me. This was a patient that I had worked with 2 years prior who had had tongue-based surgery and presented to our clinic after 10 days of a sudden change in swallowing function, inability to tolerate his secretions, weight loss, malnutrition, dehydration. And this, whoops. Go back. This is what we saw. You'll notice significant oral impairments with oral bolus control, poor tongue-based retraction, reduced laryngeal elevation, pharyngeal squeeze. It's resulting in penetration and subsequent tracheal aspiration. And this was a significant decline from what I knew when I had met him 2 years ago. Lots of struggle. When we look AP and actually look into the esophagus, we discover that he has a complete esophageal obstruction. So the problem in the esophagus significantly impacted and deconditioned the oropharyngeal phase. And I can tell you that because when we look 2 weeks later, after dilation, we see quite a different picture. He certainly has continued oropharyngeal impairment, but notice how much more efficient and how much safer swallow is after the obstruction is cleared. And even with rapid consecutive swallows, he's quite safe at this point. And then we turn and look AP and scan the esophagus. We see a really nice patent esophagus at that point. We also know that oropharyngeal and esophageal disorders can co-occur. Here's a case of a patient with known myasthenia gravis and achalasia, and if you look at the x-rays on the left, we see on the top premature spillage to the vallecula, and below that some post-swallow residue on the tongue base and vallecula. And this patient was actually an 87-year-old gentleman referred by neurology because of an aspiration pneumonia, and he assumed, potentially rightly so, that the myasthenia gravis was the culprit. In fact, when we scan the esophagus, we actually see that it's the vigorous achalasia that's the culprit, and we see backflow to the level of the vocal folds on the exam. So this patient actually did need a PEG tube, but not because of the oropharyngeal deficits, but because of the esophageal phase problems. He had a PEG tube, had Botox to the lower esophageal sphincter, and was able to resume some oral feeding for pleasure and to supplement the tube. And finally, I make the case for the concept of oropharyngeal and esophageal interrelationships, and Dr. Jones, one of my heroes, has published extensively on that, and she tells us that approximately 35% of patients with complaints at or above the jugular notch have simultaneous pharyngeal and esophageal abnormalities. Over half of patients with achalasia have been found to have combined abnormality. We see the same thing in diabetics, in patients with GERD, and most recently, Dr. Martin Harris and her group have found a correlation between impaired esophageal clearance and a delayed pharyngeal swallow. So we know that there's data out there that supports that interrelatedness. We know that dry swallows can impede secondary peristaltic wave, and I don't know about you, but that is, cookbook 101 for the speech pathologist. Swallow again. And oftentimes that can actually, in a certain population of patients, impair the esophageal wave. I'll show you an example in a moment of esophageal dysphagia, how it can cause cortical inhibition. We saw a case of muscle wasting from malnutrition that actually can exacerbate borderline oropharyngeal deficits. And we know that esophageal obstruction can cause sialuria, or increased saliva production. In that gentleman I showed you a moment ago with the complete obstruction, he went to ENT, and we had a view of his pharynx, and it was just covered in secretions. And one might have thought that it was the head and neck cancer, but in fact it was the body trying to clear the obstruction. A couple final examples of this interrelatedness. This is a young woman, a grad student at USF, who was in social work planning her wedding under an awful lot of stress, but a couple months before had a sudden episode of sensation of a wall in her throat and was unable to swallow anything more solid. She had a modified barium swallow at an outside facility, was able to do the liquids, but as soon as she put anything solid in her mouth, she spit it right out and the study was terminated. So when she came to see us, we started with a liquid, which you'll see is completely normal. We've got a pureed texture in the mouth now, and you start to see this groping movement, the inability to form it into a cohesive bolus, just moving it around. We're all getting fluoride like crazy at this point. We keep trying to shut it off, wondering when is she going to swallow. And this is what, at our facility, we coin cortical inhibition, and that's the inability to trigger a swallow orally in the absence of any neurologic impairment. When we pair it with a swallow of water, and I tell her swallow the water, she's able to swallow the bolus down. This bought her a GI consult, and she ended up having eosinophilic esophagitis. There was actually a subtle stricture that we picked up on the barium follow-through, and she was doing quite well, and I will tell you that she was able to enjoy her wedding cake. And then finally, this case just wrapped up last week, is a young woman with aerophagia and belching. And let me show you that. Okay, great. Interestingly, we had just finished a course of muscle tension dysphonia treatment for her, and she was complaining of a lot of swallowing problems. You'll notice pre-treatment, anatomy and physiology is normal, but we see this backflow from the esophagus and this free opening of the UES. It's even more dramatic on AP view, and there she is excusing herself, putting her hand up to her mouth. So we get this to and fro movement. The question is it behavioral or is it organic? When we gave her a pudding bolus, everything really stuck there in the esophagus. The gastroenterologist considered doing manometry, but deferred to us and asked us to do a little bit of behavioral therapy first. When we were able to extinguish the belching, we got a much more normal pattern of swallowing, not normal completely, but now they're able to do that manometry and get valid results. So in summary, I believe that MBS is a critical tool for assessing swallowing relationships and disorders, that good studies need to be both protocol-driven and individualized to meet your patient's needs, that we probably can and should make some esophageal observations with support from your facility and speech and radiology governing boards, but we need professional collaboration and continuing education for widespread use of this esophageal observation. But most importantly, we need to do that comprehensive study to help our patients so that we get efficient provision of care in this era of cost containment, patient safety, and quality management. Thanks so much.
So, this is very interesting to me because we've been actually utilizing esophageal screens as part of our protocol for many years, and it came out, frankly, out of desperation because we would see a lot of patients, especially outpatients, who would come to the center who would have had workups prior, and essentially they were coming to us because they said, well, it must be in this person's head. And so, the classic barium swallow and oropharyngeal study really was essentially normal looking until we started to utilize as part of our protocol what you touched on, Joy, beautifully, is looking at not only using a barium tablet with some level of consistency, but also solid food, because during the standard esophageal barium studies that were done in our facility, it's done with only liquid contrast, and so we would very often miss a lot of what was going on. And so we've now incorporated utilizing semi-solid, solid, and liquid, and at times, in addition, utilizing the barium tablet as part of the protocol. So my question in regards to the protocols, if a clinician is going to then utilize esophageal screening as part of their oropharyngeal and esophageal screening protocol, do you think that we should make that part of the protocol as a standard part of the protocol, utilizing more than liquid?
Well, I think one thing we've learned today that there is no standard protocol for the oropharyngeal phase, so it makes it incredibly difficult to standardize the esophageal phase. But certainly, I believe that would be a useful addition. Dr. Allen's study showed the clinical usefulness of using a liquid swallow. If we're doing an AP view, as I believe we should, it wouldn't take much more time or radiation exposure just to follow that view down through the LES. We standardly give a barium tablet for the oropharyngeal part of our study, so again, that's not a problem. If we're giving it anyway, we're going to follow it through to make sure it gets to its destination.
I would like to comment on the screening with the tablet. There are patients with a high cervical web. You might see where it's quite difficult. It should not happen that one gives such a tablet to a person with a high web, because that could be regurgitated and lead to aspiration of the tablet. So I think we have to be very clear on the upper sphincter and the cervical esophagus as well before we establish a tablet test.
We have, after Jackie's comment, we have one audience question.
Hi, I was just going to comment on that actually when we're always giving a bolus before we give the tablet, so you do have a look at the cervical esophagus beforehand, and quite frequently, if you've got a normal DSS protocol at the start and then you do your AP screen to get yourself right, you'll see the barium stuck there from their paste. Stuff's already stuck there, straight away something's going to happen in the esophagus. So, I mean, even if you don't even administer them another bolus, you can tell where the problem's arising. And so then if you want to give them liquid and make sure they don't have a very narrow cervical esophageal problem before giving them your barium tablet, I think you're good. And certainly where I am, because of we run the studies and there's not a billing issue at all. If we are there with and I do the studies with my speech pathologist, and if we're there and we think, hey, let's have a look at what they do when they eat their solid, then we'll also screen the esophagus with that. So this screen here may be just the tip of what you do, and obviously the more you do, the more it progresses towards an esophagram, but it's about the utility of the study. Yeah.
Is this a comment, question, or a
question.
comment masquerading as a question? Which is okay. I'm teasing. Come on.
Sorry. Hi, thank you for the presentation. Ken from USC. One question is, why are we prohibiting to bill MBS and video esophagum on the same day? Do you know any answer?
Well, I don't know that I know the answer why, but in Florida, Medicare, and I assume other states too, there's an edit that prohibits that. My understanding, just like there are other edits for Medicare for performing various laryngologic procedures in the same day, that it's been considered to be the same test when we know that that's not the case, but there hasn't presumably been enough lobbying and education on our parts to get that rectified.
Thank you.
Great question. One last question as we wrap it up for our guest from Austria. How can we inspire more of our radiology colleagues to give a crap about this? Because, they're so important.
What we do is constant education, but I went exactly to the level of the undergraduate student. And the best way to bring radiologists to do something is to refer. And by educating those who refer the patients, they demand the investigation, so I hope that will come again. But I would like to indicate there is a small lost group of patients who do not have swallowing specialists around, and these are those patients who refer to gastroenterologists for esophageal workup, but have pharyngeal disorders. And so this is very important to make gastroenterologists aware, to send it to the radiologists with severe hands for swallowing, so that the pharyngeal problems can be brought to SLP judgment, lost in gastroenterological units. It's also a proportion of patients.
I could turn the question back on otolaryngology. With some rare exception, they're just, that's why the speech pathologists are so critical in driving this, because most otolaryngologists, it's a minority of them that are really fired up about taking care of swallowing problems, because there's hardly an operation for it, rarely an operation for it. But that's it. That's the truth. So anyway, I'm glad we're here. The DRS is a special place, and thank you for a wonderful session. Thanks, everybody.